Thank you very much also to be able to join you today in this webinar. Within the next 15 minutes, I want to share with you some more theoretical insights based on the presentation Tony gave about more the practical experience we see, but more what are the theories and how we can evaluate integrated care. So how can we move from theory to practice? And these are the three main topics I want to discuss with you. So first of all, why integrated care? I think Tony already pointed out why we need integrated care, but just a quick summary. Then following by conceptualization of what we think integrated care could mean from a more theoretical perspective, and then focusing on the measurement and differences we see across countries, to also as a learning experience that will later on focusing on the implementation. So what do we need to have in place to make this for success or to achieve the triple aim? So first of all, why integrated care? And if you look around the world, as Tony already pointed out, is that we have, especially in high income countries, I think this is the problem. We face fragmented healthcare system, and especially for people with a high and complex need, this becomes a problem because they're stuck in the different silos within a system. And here on this slide, you see the fragmentation between primary care and secondary care, but we also have fragmentation with primary care, social care, and we have different barriers within our systems in terms of finance, data sharing, education, and so forth and so on. So I think globally the biggest challenge is how can we break down these walls we've created in our systems, so especially people with a complex need are able to navigate smoothly through the system. And I think you're all familiar with this this issue we're facing. But if you look at the current gap we're facing, it's quite impressive and even shocking. If you look on the right-hand side, you see the global demand in terms of what people need in terms of care within the upcoming years. First of all, aging. We know by all especially the high income countries and already the middle income countries are aging. So in 2050, already 22% of the global world population will be defined as elderly. And this is not by itself a problem, but we know that people are not aging even more healthy. So they will come with a healthcare needs to the healthcare system. And if you look in the current OECD registration, we already see that 50% of the disease burden is caused by people with so-called multimorbidity, with two or more diseases. And this means that our disease-specific standards, protocol, education system, and services we're providing will not be able to sustain in the long run. And if you look at costs, it's every year globally increasing, and it already takes a lot of budget from different countries of the social budget. So we're also facing a budget question here. And if you look at the supply side on the left-hand side, as already pointed out, we have a poor coordination of care, which is caused by the lack of accountability across care and health and social care providers. So who is accountable for an elderly person that gets an hospitalization, for instance? There is no good role distinction between who is accountable for the coordination of care. And if you look at globally at different countries, you see a misalignment in payments incentives, which means instead people are not incentivized by working in a coordinated or integrated manner, which causes a lot of fragmentation problems we see. And another problem we're facing, if was already explained, the main aim of integrated care is achieving the triple aim. And if you want to do that, we need to have transparency and outcomes. So transparency in quality, cost, and experience outcomes. And if you look in an average healthcare system or a country, we don't have, there's a lack of transparency in terms of outcome. And last but not least, we already know based on data that is reported that 30 up to 50% of the money we spend in a healthcare system is pure waste of money by duplicates or services, medicines, and so forth and so on. So it's also not, in a lot of countries, not efficient. And last but not least, we also know that medical harms like unwanted hospitalizations, polypharmacy, and so forth is caused in 25% of the cases by the bad coordination of care. So people have an adverse outcome because we as providers are unable to coordinate care in a better way. And you all understand, and this is in Ireland, I think nothing different than here in the Netherlands, this is the big challenge we need to solve together. Otherwise, the system will crack. And of course, we need an integrated approach for this. And if you look in the literature and see, okay, what is integrated care about, then I really recommend you to read the paper of Kotner of 2009, because I think this paper still makes sense, because it summarizes beautifully what integrated care is and what integrated care is not. And basically, as we talk about integration, it's like a blind man touching an elephant. We're all aware of the one little piece of the elephant we see, because it's so complex to integrate across different sectors, care providers, financial systems, and so forth and so on. So integrated care as a concept is an imprecise hodgepodge, and its meaning are as diverse as the different stakeholders involved. So as a patient or a care provider, my perspective of what integrated care is will be differently. And I think this is nicely described in this article, and he already states that integrated care is a means to a certain end. And basically what Tony already told us, it's towards the triple aim, and therefore you need integrated strategies. But if you look in the literature, you end up with almost 200 definitions of what integrated care could be. So that makes it very, from an academic perspective, already very complicated to start measuring things, at least starting implementing it from a different perspective and definition. And that makes integrated care also very complicated. So to give you what I use as a definition, but you can use your own, but I think this makes the combination or the link between integration and the outcomes. I think this definition gives some better insight in what integrated care is. Integrated care can be defined as patient achieved outcomes and experience of care in combination with the amount of money spent by providing accessible and comprehensive and coordinated services to a targeted population. The group of providers is collectively accountable and willing to take risks to achieve basically the quality and cost of care, or the triple aim. So this is essential. So if we want to achieve the triple aim and want to integrate the services, also the providers have to take a certain risk. Otherwise we're stuck with projects, and projects per definition don't sustain within a system. So this is, I think, a critical insight to keep in mind when you're involved within such a project. And these are the key characteristics already explained by Tony. It should be person-focused, looking at someone with a need in the broader context of his or her social context. It's intersectoral collaboration by definition, based on the needs of a particular patient or patient group. And it's doing business together and taking risks together. Otherwise, it won't work. If you don't share the risks, it's stuck in a project mode. And last but not least, it's about realizing change or results. So being able to show your progress in terms of outcome measures and not only process measures. And what we did, we tried to bring this together in a conceptual model, which is basically, I think, a solid summary of the previous literature of 10 years of integrated care. So what does this model learns or tells us about integration? First of all, if you look here on the bottom of this slide, you have two approaches to start integrating care. First of all is person-focused care. So looking at the needs of an individual and its values. What needs do we have to address? And second, but this is on another level, I would say the meso and macro level within a system, we talk about population-based care. And that's community-oriented care coordination activities. So this is another level. You also need to have, I think the examples Tony showed us are a lot of examples were focused on population-based approach started off by a Ministry of Health, for example. And it's good to have this distinction, but between both are necessary, but are on an aggregation level, they are targeted. So if you move on with this conceptualization, so we have like focus, you have two enablers which make integration work or not work. And I think the next presentation about implement will focus on this. But you have like the soft side, which we call the normative enablers. It's about the supporting culture to link to different service providers. And on the other end, you talk about the functional enablers. This the supporting infrastructure. So about sharing data in terms of other contracts by financing integration. This is more the hard approach, I would say, to achieving some form of integration. So these are the enablers. But we're not there yet. We also have the different drivers or integration mechanisms we call. And this are the different bows within this rainbow model. At the micro level, it's about service or clinical integration. It's the interaction between a patient and a care provider. And it's the coordination of care at an individual patient level. And this is where we talk about value creation. This is where the value creation at an individual patient level happens. But if the cohort of, for instance, diabetic patients or people with anxiety or depression is very high in a certain community, you can't not integrate service. You need to move up to another level. And then we talk about the meso level, and the first thing we touch here is professional integration. That's the coordination of care among different care providers. They need to make arrangements to address the needs of a certain population you have included within your approach. But the critical thing is that's not enough, because all those providers are linked to a certain organization or institution, and they need to integrate their services as well. And then we talk about organizational integration. And that's the coordination of care among different organizational units. And this is a fundamental thing to also address in your approach, because we know by a fact that this organizational integration is the hardest thing to achieve in practice, because it's very difficult, and it touches a lot of business models of different organizations involved. And last but not least, we have system integration. This is the influence of local laws and regulations which enable or not the different forms of integration both below, the different forms at the different aggregation levels. And the assumptions or hypothesis is, if you integrate on these different levels, you're able to achieve the triple aim. So lower costs, improve health of a population, and the quality of care or patient experience. So this provides, basically this model provides a theory to start conceptualizing what forms or enablers of integration do we need to achieve the final outcome in terms of triple aim. And the critical question is, we started off with this model in 2013, is are we able to measure it and to approve these assumptions? Because basically, as an academic, you want to measure it and see, does it make sense to integrate services, and are we able to achieve a better outcome? So this is the journey we are making or have made. So we started off with this model in 2013. Thereafter, we had different focus group Delphi studies to start to work on an operationalization of the model. So working towards a measurement tool, so we were able to measure integration in practice. And in 2017, we started with the first international study where we were able to include a cohort of 90 up to 20 countries, where we were able to measure integration from the perspective of patients and care providers in 19 different countries. And this study is replicated for this year again and next year. So we will now have some data, which I will show a couple of slides with you, where we understand the difference in integration as perceived from the patient's perspective. So we worked on, as I already explained to you, two measurement tools, basically online surveys, one for the care providers. So as you can see, all the different domains within the rainbow model are measured from the care provider's perspective. And on the left-hand side, you see the tool which is developed for the patient. It's called a patient-reported experience measure, and there we measure only the 4 bows, so to say, of the rainbow model. So person-focused care, clinical coordination, professional coordination, organizational coordination, because the assumption is that patients don't experience the back office activities which enable integration. So we didn't include that for the patient survey. We psychometrically tested the reliability and validity of the skills, and here you see a summary of those measures. So we were able to validate basically the conceptual model. So here you see the different countries which were embedded in our sample, and also the different languages with all the translation. And I will show within 2 slides some the experience patients have across those countries in terms of how they experience their integration across the system. So what do we see in practice if we take the patient eye in terms of integration across the system? And this is all particularly interesting to look at with the presentation of Tony in our minds, because it might tell us something different. So here you see, this is the global rating on the different scales in the model. And here you see the 90 countries which were included in the sample of 2017. And we don't have a golden standard to measure integration from the patient perspective. So we took the global average, that's the red line presented, to start and benchmarking country. And interestingly enough, if you look at those countries, you see the UK, and Germany and Australia scoring below the global average. And this is interesting because I didn't expect that the UK was going to score below the global average, or at least at the lower levels, because they have an investment agenda for many years already on integration. And I thought Australia would also do much better. But if you ask patients, they tell you something completely different. And this is interesting to get some insight in how countries might be performing on this agenda. And if you take a look, and this is the particular measure of person-centered care experience. So do people feel that their needs and values are addressed within the care approach? We benchmark the countries again. So here you see the average on the lower hand side of the slide, the person-centered care experience compared to the overall care coordination experience. And again, you see that patients in the UK, which were included in this cohort, in this sample, rate that they have a disconnected care experience, which is quite remarkable, because I would not expect that based on the policy papers I was reading from the NHS. And also in Germany and Australia, the patients indicate that they have a fragmented care experience. Also something, Germany, you could argue, yeah, that would something we could expect based on what we know about the Health Services Organization. But Australia, I would not expect that. But this is what patients are telling us. And if we move on in terms of clinical integration, so do people feel that in the primary process care is well connected across the different care providers they see? Again, the patients in the UK tell us that they face a disconnected care experience, and also in Germany. And in Australia, again, a fragmented care experience. So again, this tells us something. Okay, policy-wise, we might be thinking we're heading in the right directions, but that is not by definition the same as patients might experience it across the care continuum. And this is particularly interesting to start looking at what are the top performance here, and what do they differently in their approach. And we're now in a phase where we are able to link the different care coordination experiences with some AAA outcome measures to see if we can detect a correlation between a higher level of integration in terms of AAA outcomes. So this already, we found some correlations, and this makes it interesting, because this provides evidence that improving integration is indeed a good thing to do because it also addresses a patient need, but it also enables to improve a clinical outcome by the end of the day. And this is the kind of evidence we need within our healthcare system, and also to move this in the right direction. So this is my concluding slide in what is needed to move from theory to practice. And I think there are some things are fundamental. First of all, you need a conceptual model, and you are able to theorize it and then to measure it, to start convincing people how should this work in practice and crack the black box of integration. And I think we have now able to validate one instrument which measures all the aspects of integrated care. And if you look at the previous study, most of the instruments or approaches only measure one piece and mainly focus either on clinical or professional integration. And we all know it's broader and more complex than that, and that needs also to be included in your approach. And also, what you see, a lot of these instruments are very complex and that makes them unsuitable for daily practice. And this instrument was used in daily practice in different clinics, and it was short and generic, which makes it also applicable across different chronic diseases and patient groups, which we're now able to see differences between different integrated care approaches. And in terms of using instruments, it's also very fundamental that you use like real solid instruments with a good construct, validity and reliability. And this is also, well, the instrument I presented to you also has very good construct, validity and reliability. So you're able, you know what you measure by the end of the day. And I see a lot of projects which don't use these kind of measures, which weakens your approach by the end of the day. And they provide information, as you saw in the different graphs, gives you some insight in the quality of care, how patients experience it. And I think this is fundamental to start your improvement approach, because you need to know what a patient is thinking about the coordination or discoordination of their care. And last but not least, this provides you information to start optimizing care, and therefore you need to have like data or at least some kind of measures that you're able to improve. Well, I think the next speaker will focus on the implementation. Thank you very much. And if you have some questions, they can be answered later on during this webinar. Thank you very much.